Does your doctor know about the contraindications for the prescribing of statins that aren't covered in the guidelines? That's this week's topic. Stay tuned. In today's video, I'm going to do something a little different. I'm actually going to talk about a case study for a medical treatment that has got nothing to do with statins. And the reason for that is I just want to show that it's not just in the world of statins where we have these problems, and there'll be some good analogies here. If you don't want to bother watching this part, there will be a time link in the description so you can skip on ahead where I talk about these statin contraindications. First, I need to get into a little bit of definitions here. The prefix hyper indicates something is either high or overproduced or excess. It means there's too much of something. For example, hyperglycemia, too much sugar in the blood. Hyperinsulinemia, too much insulin in the blood. Hypercholesterolemia, a little bit controversial here in my mind, but when there's too much cholesterol in the blood. Hyperparathyroidism, which is what I'm going to talk about first, is when the parathyroid glands are overproducing parathyroid hormone. Conversely, the similar sounding prefix hypo is exactly the opposite. It indicates low or under or deficiency. And examples of that: hypoglycemia, low blood sugar; hyperthyroidism, underperforming thyroid. Today I will be talking about both the thyroid and the parathyroid. Thyroid is a gland in your neck region. Parathyroids are small rice-sized additional glands that reside on the thyroid, and they perform a separate function. Today's non-statin example, we're going to talk about hyperparathyroidism. First question is, what is hyperparathyroidism? It comes in two forms. Primary hyperparathyroidism is when there's an enlargement of one or more of these parathyroid glands, and it causes an overproduction of this hormone that I talked about. So it causes hypercalcemia, that is too much calcium in the blood, which can cause a variety of health problems. Then there's secondary hyperparathyroidism, and that's the result of some other condition that's lowering the calcium, and the parathyroids kick in. They're actually doing their job and they are functioning properly, but something else in the body is keeping the calcium levels too low, and the parathyroid glands are just trying to do their job. So they're basically redlining, pumping out parathyroid hormone to try restoring the calcium levels. So the treatments for these two things are considerably different. For primary hyperthyroidism, surgery is generally currently the only treatment where the overactive parathyroids that are just running wild for no particular reason other than they're broken, those get removed. For secondary hyperparathyroidism, help the parathyroid restore the calcium level by prescribing prescription level vitamin D. But we have to be careful of the danger of vitamin D toxicity, because that can lead to hypercalcemia and an imbalance in the regulation of bone metabolism, and it leads to the same health problems that we were just talking about. So now let's look at a case study of this particular condition. It's something that I was involved with and know quite a bit about. First of all, a patient, somebody close to me, presented with high parathyroid hormone and hypercalcemia, which indicates primary hyperparathyroidism. The primary care physician prescribed megadoses of vitamin D. Over time, the patient became unable to perform normal daily functions without assistance and needed assistance getting in and out of a bathtub, for example. The primary care physician told the patient, things are going bad here, you better keep on taking that vitamin D. Well, this went on for quite a while, and neither I nor the patient made the connection with vitamin D. We were just following the doctor's orders and think, oh, things are going really bad here, and we really have to get in to see an endocrinologist about maybe surgery to take care of this problem. There's a problem that endocrinologists are in high demand, and sometimes you can't get in to see them for 6 or 7 months, and the patient was just, I can't live like this for another 6 or 7 months. I've got to do something. So we called in some favors. A doctor that the patient used to work for had an endocrinologist friend who did him a favor and put this patient at the top of the queue, and we got in to see him. Well, the first question he asked was, what are you doing for this hyperparathyroidism? And the patient told him, well, I'm taking megadoses of vitamin D. He said, when was the last time you took it? The patient said, well, I take it weekly. I would be taking it today. I haven't yet. He says, don't take any more. Stop taking it. Well, the patient's condition returned to normal for that patient, went on still to have surgery to correct the problem. There are conditions where it may be appropriate to prescribe vitamin D to somebody with primary hyperparathyroidism if they're asymptomatic. And what that means, after I did a little research on that, is that they don't show high levels of calcium. They're not also hypercalcemic, along with having the hyperparathyroidism. And while there may be conditions where it's appropriate to prescribe the vitamin D, there is no condition under which it's appropriate to prescribe the vitamin D without following up and checking the results. And that's what wasn't done. So what's this all got to do with statins? There's a minor, very personal connection here, and then there's a more generic connection. So let's look at that. The minor connection is that the same doctor who prescribed the megadoses of vitamin D to this other patient also was the one who browbeat me into taking statins. So in my book, her batting average is 0. More pertinent, though, is that there is an analogous circumstance that even by conventional pro-statins standards, that statins are contraindicated. One cause of hypercholesterolemia can also increase the likelihood of statin intolerance. And the reason I emphasize it like that is because I have arguments with the whole concept of hypercholesterolemia being a one-size-fits-all value. So what are we going to talk about today? Well, we're going to talk about hypothyroidism, and I apologize that I was just talking about hyperparathyroidism, and now I'm talking about hypothyroidism. It gets very confusing when I'm talking to people casually, like on a walk or something. They get very confused because, well, wait a minute, which condition is which? So we've got to keep that straight. Now we're talking about an underactive thyroid, not the parathyroids. They're out of the picture. Set them aside. Hypothyroidism can be a cause of hypercholesterolemia. Put that in quotes because, to me, hypercholesterolemia should be defined as way too high for what is natural for the particular individual. For example, somebody who is a lean mass hyperresponder, a level of 400 total, which is somewhere around 9 or 10 millimoles per liter, may be perfectly normal for them and not a hypercholesterolemic condition, whereas for somebody else, a level that high would be outside their normal range. So let's talk about hypothyroidism and statin intolerance. I'm going to run through just a bunch of papers that I found on the topic, and we're just going to go through them quickly so you can get an idea of what's going on here. First, the coexistence of statin therapy and hypothyroid states may synergistically increase the risk of myopathy. And then they talk about elevated CK. I haven't talked a lot about that, but that's common when there's cases of muscle pain. When statins are combined with a hypothyroid state, it can increase the possibility of rhabdomyolysis. For this reason, physicians should consider temporarily withholding statin therapy during periods of induced hypothyroidism. They were talking about a very specific case where they induced hypothyroidism. Iodine 131 is a radioisotope of iodine and that kind of therapy. So this was a very specific case, but nevertheless, it does have wider applicability. Hypothyroidism is more prevalent in those with statin intolerance. People with hypothyroidism are less likely to have prescription for a statin at follow-up. That's an interesting way of wording it. And I think what they mean is people are more likely to experience these adverse effects and they just stop taking it. So when they follow up, they say, no, I'm not taking that stuff anymore. I'm not filling the prescription. So I think that's what they mean here. If, however, the cause is connected to an underactive thyroid, then medication to treat hypothyroidism may in turn reduce cholesterol levels. Okay, that's great. And they go on to mention one particular drug which is commonly used, which doesn't seem to lower those cholesterol levels. But I think this is a very telling statement at the end. This is from the Thyroid UK website. Don't let higher cholesterol scare you into taking statins without getting your doctor to check all your thyroid levels. Next paper, anyone who has been diagnosed with cholesterol abnormalities should have a complete thyroid hormone profile conducted. Cholesterol drugs may affect your thyroid gland and reduce thyroid levels, possibly causing or contributing to hypothyroidism. So it works both ways. Speaking of side effects, muscle problems are at the top of the list. Statins are far more likely to cause muscle pain, cramps, and skeletal muscle damage if you already have hypothyroidism. You can see why it's important to have a thyroid profile done at least once a year and more often if you take a statin. Is that being done? Is your doctor checking your thyroid function? I never had mine checked, not by a doctor while I was on statins, so I doubt that this is done commonly. Next, we have from the Canadian Family Physician an article where they said this case, it was a case study, demonstrates that using statins in hypothyroid patients is dangerous. The dangers of statin use in hypothyroid patients have been illustrated. Unless you think that I'm just quoting anti-statin articles, the author of this article is actually very pro-statin. Look at the highlighted statement here. Statin therapy is safe and effective. I disagree, our viewers disagree, but this author felt that statins are generally safe and effective, but calls using them in a condition of hypothyroid patients as being dangerous. So we can see that it's all coming together with a consistent story. Next, last two that I'm going to talk about. People with hypothyroidism treated with this particular medication that is quite often used are also often prescribed statins because the normalization of the thyroid function with this particular medication for some reason just doesn't result in a normalization of cholesterol. Here's the result they pointed out. An unaware doctor could end up prescribing statins in this case even though they're contraindicated due to increased intolerance in the presence of hypothyroidism. And then in another paper, the present study confirms that statins enhance levels of CK, we've already talked about that, in patients with hypothyroidism. We must not begin and continue to use these drugs without checking the possibility of hypothyroidism. And that's from the Endocrinology journal, and it's actually quite old. It's nearly 20 years old now, so this has been known for quite some time. So my closing thoughts on this, well, there's one very specific one, and that is if your doctor is talking to you about statins, make sure that your thyroid function has been checked first. And if you have an underperforming thyroid, maybe that's the reason that your cholesterol levels are out of bounds for what's safe for you. More generally, these cases show us that it's up to us to protect ourselves from mistakes. Doctors can make mistakes. They're human beings like the rest of us. We know the pressure they're under. In the United States, the medical healthcare system is in such a state that they only have a few minutes to spend with you. They're pretty much just medication prescribers. So we have to take the lead in what our treatment is and just consider our doctors part of the team. They have special knowledge and we should take advantage of that, but there's times when we have to make the decision for ourselves. So that's what I've got on this topic. If you appreciate this content, please like, share, subscribe, all that good stuff, and comment on this topic. There are others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.